here I'm going to speak about update, but it's a well-known disease. Was described actually by an ancient great scientist like 500 BC, and it's by the name of Silesus. And this guy actually, he was characterized the disease by having patients with polyuria, lack of pain, general weakness, and fluid output greater than the fluid intake, and also weight loss. And since that time, actually, initially, they put actually the strategy for the treatment. And they don't have a lot about medication at that time, but they start by using diet containing a minimum amount of food, so less caloric intakes, at the same time regulate mode of lifestyle. Still, even till now, we're using actually this as first line in the management of diabetes. So to speak about diabetes, we have to solve certain challenges that we have. And I will speak about these issues now, and later on I will go through them and present them again in the end of my talk. So the high burden of the disease. If you look here for the diabetes, have many people actually have complaint of diabetes. I will go into more detail. Progressive nature of the disease, decline in the beta cell function with time, monotherapy is not durable, clinical inertia, hinder glycemic control, and compliance and adherence. So to understand diabetes, we have to know a little bit about the pathophysiology of type 2 diabetes, and it includes actually three main defects. One of the defects in the one of the defects in the pancreas, in the liver, and in the peripheral tissue, muscle, and fat. So what we can found in the pancreas, actually, the islet cells, which have both beta and alpha cells. There is a decline in the beta cell, which produce less insulin, and there is excess of the alpha cell, which produce glucagon. The excess glucagon and the less insulin will affect the liver, and by this you will have like increased gluconeogenesis and have hyperglycemia. At the same time, diminished in the insulin in the peripheral tissue will also have decreased glucose uptake and result in hyperglycemia. Can I have a pointer, please? Give me one. Okay, you're a little bit down. Okay, so if you look here for type 2 diabetes is a vicious circle driven by insulin resistance. So there is insulin resistant, which add stress on the pancreas for further beta cell dysfunction. And beta cell dysfunction will reduce the insulin level in the blood, potential effect the insulin resistant. So this keep going on and on. And the risk factor for type 2 diabetes are age, more than 45 years of age, overweight, family history of diabetes, lack of regular exercise, and certain racial and ethnic groups. We have it more common actually in African American, Latino, Asian, and Pacific Islander, and Native American. And history of gestational diabetes or give birth to more than 9-pound newborn. So here the impact of the disease, you know, it's a global epidemic, and in 213, almost there is like 382 million people worldwide living with diabetes. And this number is projected to increase to 592 million people worldwide by the year 2035. So actually, look again in the number. This is a huge number. So in the Gulf, by year 2011, there was 1.5 billion individuals with diabetes. And this is going to be like in year 2030, 3.7 million. So expected growth is 137%. According to the International Diabetic Federation, Kuwait is among the top like 5 countries in the Gulf with the diabetes, with the prevalence of 23%, just after Saudi Arabia was 23.9. So here, actually, for the prevalence of diagnosis of diabetes by age and sex, The prevalence increase with age, definitely, and the sharpest increase occur after the age of 40 years. And the highest prevalence is in the 75 to 79 years of age group. And if you look to this category, you will find actually also here like male more than female. So that's, I mean, regarding this, it's more common in male than female. So the key challenge in the diabetic management is the control. And that's usually what we face when we are treating our patient. We know the diabetes, we know the diagnosis, but how we reach a good control. Many study was done actually here, and they are big study involving good number of patients, one of them in China, in Canada, United States, and in Europe. And in the China, you have cost of diabetes in China. They involve almost like 5,000 patients, and they were searching for hemoglobin A1C less than 7.5. With this category, actually, only 68% reach that level. If you go actually for like tighter control, which is 6.5, in a study involving like 7,000 patients in Europe, they found almost like only 31% reach this amount of like hemoglobin A1C. So we need actually this type of control in order to decrease the complication. According to the UK BDS study, improving hemoglobin A1C control by even like reduction of 1% decrease the diabetic related death by 21%, myocardial infarction by 14%, and microvascular complication 37%, and amputation or death from peripheral vascular disease by 43%. So this is actually very important to have a good control. We see many patients actually coming here actually in real clinical practice with hemoglobin A1C of 8 and 10, and we say that this is okay. This is never okay, because the patient actually at high risk. Even small reduction will show an effect of your management. The progressive nature of type 2 diabetes lead to loss of glycemic control over time. Actually, if you see like initially in the management, okay, the hemoglobin A1C was kept actually around like 7, but with time it's racing, and this is like as time is going on by the years. Whatever you are using, conventional or intensive treatment. So, and that's because the beta cell dysfunction is a progressive process. So even before the diagnosis of diabetes, by almost like 10 years, you probably, or even more, you found decline in the number of the beta cell. And by the time you have the diabetes, almost about 80% of the beta cell is not functioning anymore. So that's also what's happened. You can see in a pre-diabetic patient or hyperglycemia. So initially start slowly, the insulin sensitivity start to decline progressively with time, and the insulin secretion start to increase in order to compensate, and here the failure result in hyperglycemia. Monotherapy, actually a lot of patients when they are coming, they try first be in a state of denial. Okay, we don't have diabetes, we try to solve it like by only like physical activity, diet, and so on. Or you start monotherapy on them. But even if you start monotherapy, it's not a durable, because of what we mentioned earlier is the decline in the beta cell function with time, no matter you are a good physician or who you are. So here, if you see, like within 3 years, the hemoglobin A1C was with better control than if we are on whatever type of treatment, till, getting worse by the 9 years. So here you see the diet alone was effective, but here it's not effective anymore. The Canadian Diabetic Association clinical practice guidelines, they put the pharmacotherapy checklist. Choose initial therapy based on glycemia. And start with metformin, unless that's contraindicated. And individualize your additional therapist based on characteristic of the patient and the agent. And each target within 3 to 6 months of diagnosis. So you can see here, earlier use of combination therapy may improve treating to target compared with conventional. So actually, start from the beginning, okay, by combination, it will help to bring the hemoglobin A1C around the 7, better than the conventional therapy and all the process that we start one drug, after a while another one. So sometime from the beginning you can use the combination and will give you a good result actually. So here you can see no single oral antidiabetic class target the key pathophysiology. And we know that pathophysiology, there is a deficiency, there is an insulin resistance. So we have to find drug which actually, or more than drug, to have this complementary function. So when using combination therapy, consider classes that offer complementary mechanism of action. So found something to affect the insulin deficiency. So to use something like insulin secretagogue actually in this patient, and to solve the insulin resistant by using drug which work in that issue, and excess hepatic glucose to decrease the gluconeogenesis, and some drug also to decrease the intestinal absorption. So here the major site of the oral drug classes. So drugs can function either in the pancreas, like insulin secretagogue, sulfonylurea, metiglitide, DBP inhibitor, and also like GLP receptor agonist. Same thing, some drug will work in the liver, either work in the GI, and in the insulin resistant also, in the peripheral tissue. So little thing about the history also in the management, like, you know, I mean, since 1900 years, they start by diet. Then the insulin developed around like 1920. Then we have sulfonylurea around 50, biguanide around 1970. And 2000, we have the alpha glucosidase inhibitor, glitazone, glitide. And recently, in year 2005 and 2006, we have also incretin-based therapy, GLP receptor agonist and incretin mimetic enhancer, DDP4 inhibitor. And the very recent one, actually, almost like 2011, we have the SGL2 inhibitor, which is a novel insulin-independent approach to improve excess glucose. And this drug actually will work in the proximal tubule and affect the absorption of glucose, resulting like in the excretion of glucose in the urine. They excrete about like 70 grams per day, which is corresponding to 280 calories. And they are very beneficial actually drug recently, and also have some effect in the weight reduction. And this is the latest drug so far. So the key consideration in selecting a second line therapy, we have patient-related consideration, like degree of hyperglycemia. So if I say here degree of hyperglycemia, so it's different when you start managing patient with a hemoglobin A1C of 6.5 or like 7.5 or 9 or so on. So you have to choose either from the beginning which agent you're gonna use. So risk for hypoglycemia, overweight or obese patient, comorbidities like renal, cardiac, hepatic, preference to access treatment, and agent-related consideration, blood glucose lowering efficacy, risk of inducing hypoglycemia, effect on the weight, and contraindication side effect, and cost and coverage. Cost also is very important thing to bear it in your mind. So here you can see 3 antihyperglycemic agents, 3 ideal characteristics in them. Like we have robust A1C reduction, don't cause hypoglycemia, don't cause weight gain. This is a very crowded little bit slide, but I want you to know here, when you are using a second line antihyperglycemic agent, you look actually to what we mentioned early. Relative lowering of hemoglobin A1C, so you should use drug which can have an effect on that. Hypoglycemia, try to use agents which less risk of hypoglycemia, it will be better even. And also weight, you don't want to give patients with type 2 diabetes, they are already obese with insulin resistant, a drug which increase the weight. And you can use other consideration, for example, the price or sex of the patient. Also here you can see almost like many societies, they are not different than each other. And if we go, they are almost like repetition of what we have. But I found actually here just only to present it to you in order to compare just quickly. So here the American Diabetic Association and European Association for Diabetic Study, joint position statement, they put also recommendation. Initial therapy, monotherapy is metformin or they said sulfonylurea if metformin is not tolerated, or go to second, like 2 combination, metformin plus whatever of these drugs, or 3 drug combination, metformin plus and combination metformin. Take it from me, just only from the real clinical practice. Do whatever you would like to do in the combination, just only have a drug work in different mechanism and to get the target that you are searching. The hemoglobin A1C is 6.5 or like 7 according to the American Diabetic Association. So you don't need actually to remember any of this. Same thing, also very busy slide, but the same principle, like American Diabetic Association and European here position, eating healthy diet like lifestyle modification, and go for like initial metformin therapy, if tolerated, 2 drug combination, 3 drug combination, and probably even like basal insulin, if you are not reaching the target within 3 months. Australian, as much as lifestyle, sulfonylurea, same things. Here, to tailor therapy, patient consideration, you should choose what the patient wishes. Sometimes, patient come to you and you found even you won't give them an injection, but the patient strongly said, I will not be cooperative with you if you give me injection. I'd like to have start by oral. So we have to respect the patient wishes. Same thing, age, duration, body weight, and cost, occupation, safety, ethnicity, and so on. This is a very important matter actually, and even affect our decision in treating our patient, like the clinical inertia. We actually, as a physician, we take care a lot about hypoglycemia and weight gain. We don't want the patient to have these, and the patient adherence to lifestyle modification and drug treatment. So this slide is not an odd slide. It came in here, but it's a very important slide actually.
Sorry, Dr. Sameer, 2 minutes.
How much?
2 minutes.
Okay, I'm running actually, okay. I tried my best, okay. Anyhow, quickly. So when you are choosing, don't choose a drug which can cause hypoglycemia in patient at high cardiovascular risk, because hypoglycemia is a big stress to his heart and at the same time will create ischemia or arrhythmia. So here you can see when they are comparing specialists plus like polyclinic physician, and they found using any drug intensification, only 45% of the specialists and primary care physician like 37. When you go to adding insulin, you found here the inertia like so clear. They are very hesitant, and only like 8.6 from specialist and 1.7 from primary care physician. So this slide you can see if you are using a drug which can be taken once daily, it's better than twice daily, better than 3 times daily. And you can see it clear actually the effect here in the hemoglobin A1C with different like category. So here, summary of the challenge, I will escape this. So I will go to the conclusion here. Adopt an intensive multifactorial approach treating to target hyperglycemia, as well as the associated cardiovascular risk factor, starting from the time of the diagnosis. Current guidelines emphasize the importance of individualizing the glycemic goal and therapy and involving our patient in the decision-making process. I think by this, yeah, I reach my end. Thank you very much. And I hope I get on time. I was running.
Thank you, Dr. Sameer.
Thank you.
Finished in time.